Systemic lupus erythematosus, systemic sclerosis, dermatomyositis, and polymyositis is the name of our lecture. Good afternoon, dear students. The immune system normally fights off dangerous infection and bacteria to keep body healthy, and autoimmune disease occur when the immune system attacks the own body. There are many autoimmune disorders, and systemic lupus erythematosus is one of them. Lupus is Latin for wolf. The disease was co-named in the 13th century as the rash was thought to appear like a wolf's bite. And in general, it's autoimmune multi-system disease. Rate of systemic lupus erythematosus is very different between countries, from 20 to 70 per 100,000, and women of childbearing age are affected about 9 times more than men, and average age 15 till 25 years. And we have a specific type of disease, discoid lupus erythematosus, neonatal lupus, subacute cutaneous lupus erythematosus, and of course we treat this patient in different hospitals. Sometimes patient treats in dermatological hospital, sometimes it's a rheumatological hospital with a full clinical picture of disease. Systemic lupus erythematosus has specific laboratory tests for diagnostics. It's about antibodies to native double-stranded DNA, antibodies to Smith antigen, lupus-like reaction, lupus erythematosus cells, and common symptoms of this disease include painful and swollen joints. But if we compare with rheumatoid arthritis, lupus arthritis is less disabling and usually doesn't cause severe destruction of the joints. Also very common fever, chest pain, hair loss, mouth ulcers, swollen lymph nodes, feeling tiredness or weakness. Red rash is a common feature of this disease, and appearance in the face is more common. We have picture about it, and clinical manifestation we include in diagnostic criteria as well as laboratory tests. And we have pictures of skin changes. Skin changes, mother rash in the face, ulcer of mucous membrane, and specific discoid lupus changes, cutaneous manifestation, which leads to scar upon healing. Also about internal organs. First of all, heart. Systemic lupus erythematosus may cause pericarditis, inflammation of the aorta lining surrounding the heart, maybe myocarditis too, inflammation of the heart muscle, endocarditis, also inflammation of the internal layers of the heart. So 3 layers of the heart include in process. Endocarditis of systemic lupus erythematosus is not a non-infection, and called Liebman-Sachs endocarditis. It involves either the mitral valve and tricuspidal valve, but more often mitral, of course. And atherosclerotic problems also may be present in this category of patients, more rapidly formation of atherosclerosis than in general population. Pleural effusion, pneumonitis, interstitial lung disease, pulmonary hypertension, pulmonary embolism, pulmonary hemorrhage. It's about pulmonary problems. it's very common also. Kidney problems, glomerulonephritis, lupus nephritis leading to kidney failure, and glomerulonephritis with via loop abnormalities. This findings is due to immune complex deposition along the glomerular basement membrane and leads to typical granular appearance in immunofluorescence testing and blood changes also. And we know that possible different causes of anemia, of leukocytopenia, thrombocytopenia, but first of all, immune changes and hemolytic anemia is very common, and anemia of chronic disease also may be present. Antiphospholipid syndrome with antiphospholipid antibody may be also detected, and we have changes in coagulation system and anticardiolipin antibody and very similar picture to syphilis and we provide differential diagnostics with further laboratory testing for this. Anti-nuclear antibody, first of all, and serological testing includes other type of antibodies, and direct immunofluorescence test can detect deposits of immunoglobulins and complement proteins in the people's skin. Except anti-DNA, we have anti-histone antibodies for diagnostics, and others antibodies also may be present because maybe combination of different disease, rheumatological disease, and of course sometimes we can see systemic sclerosis, mixture connective tissue disease. We can see sometimes SSA, SSB, anti-LAS, antigens, antibodies, and we should provide differential diagnostics in Sjogren's syndromes and other rheumatological disorders. Diagnostic criteria of systemic lupus erythematosus, despite of appearance new diagnostic criteria, we very like criteria of American College of Rheumatology, which includes clinical criteria and laboratory criteria. Summary, we have 11 criteria. 4 of them are enough for diagnosis, present simultaneously or serially in 2 separate occasions. First criteria, malar rash, sensitivity 57%, specificity 96%. Second, discoid rash, red scaly patches on skin that cause scarring. Sensitivity 18, specificity 99%. Also pleural infusion, pericarditis, maybe serositis, all type of serositis, and liquid in abdominal cavity also possible. Oral ulcers, sensitivity 27%, specificity 96%. Arthritis, usually non-erosive arthritis, 2 or more peripheral joints with tenderness, swelling, and photosensitivity is very common for systemic lupus erythematosus. Sunlight as trigger factor, and after summertime, usually exacerbation of disease. Blood changes, hemolytic anemias, leukopenia, lymphopenia, low level of platelets may use also as diagnostic criteria. Renal disorders, any type of glomerulonephritis, we use as we check and use laboratory test, urine test for review this, and further biopsy for diagnostics. Antinuclear antibodies is very sensitive, sensitivity 99%. Immunological disorders, positive anti-Smith antigens, antiphospholipid antibodies, serological test for syphilis, and psychiatric disorders also includes in diagnostic criteria seizures or psychosis, sensitivity 20%, specificity 98%. Treatment of systemic lupus erythematosus. First of all, should be diagnostics from rheumatologist. General recommendation: avoid sunlight, use sunscreens, and then treatment is very different. It depends of severity, it depends of form. We can use non-steroid anti-inflammatory drug. We can use topical or low-dose steroids in case of skin changes. We can use anti-malaria drugs in case of not very severe changes, and we use azathioprine, cyclophosphamide, high dosage corticosteroids for serious visceral involvement. About second disease, scleroderma, also known as systemic sclerosis. Sclerotic skin changes often accompanied by multi-system disease. Progression fibrosis from increased collagen deposition in interstitium and intima of small arteries and connective tissue, maybe different form, maybe full form with aggressive systemic disease, maybe only skin limitation form. And of course, skin includes different areas: face, hands, feet, and visceral organs also may be very different: kidneys, heart, lungs, gastrointestinal tract, and others. And accumulation of connective tissue in the skin is the main presentation, and etiology unknown. Clinical characteristic: vascular damage, first of all, immune activation, synthesis and deposition of extracellular matrix. Quantity of scleroderma is not very big in population, 4-12 new cases per million per year. Female also more common than men. Average age of onset between third and fifth decade. Genetic association in this disease is present. Sometimes trigger factor after using of any chemotherapy, after using of polynucleotide, benzenes, bleomycin or others, anthracyclic antibiotics, and maybe unknown origin at all. In pathogenesis, we discuss about autoantibody production, chromosomal abnormalities, and the cellular cells dysfunction. Fibroblast activation, most common in the skin, but also in the internal organs. And we may discuss the role of cytomegalovirus, parvovirus B19 in the genesis of the disease. More about pathogenesis in this picture. And the cellular dysfunction, the cellular damage is common for this disease. Okay, about clinical manifestation. Skin changes, thin epidermis with compound bundles of collagen parallel to the epidermis, dermal atrophy, and gastrointestinal tract involvement, atrophy of muscular in different levels, esophagus, intestines, and we have also pulmonary problems, diffuse interstitial fibrosis, and peribronchial pleural fibrosis, any cysts may appear. Pulmonary hypertension is a result. Cardiac involvement, irregular fibrosis, most common, and sometimes leads to heart failure. Renal involvement, renal arteries, fibrinoid necrosis of afferent arterioles, and acute renal failure also possible in this disease. Diagnostic criteria, proximal damage of skin, except wrist, is a major criteria, and minor criteria, second of following, sclerodactyly, digital pitching of tissue loss on the volar pads on the finger tips, basilar fibrosis on X-ray. It's about minor criteria. Okay, and one major criteria and two or three minor criteria are enough for diagnosis. Okay, scleroderma also may be present with renal syndrome, with visceral manifestation, and with calcification in soft tissue. We can see in X-ray any changes and visible superficial changes. R means renal disease. It's very interesting symptomatic, which with changes of color, different part of the body, usually distal part, fingers, during short period of time, change color, blue, pale, and then redness. It depends of microcirculation problems. Also, dysphagia, xerostomia, xerophthalmia, laryngeal involvement, hoarseness is very common for this disease. And also we have next letter E. E is for esophageal dysmotility, motility first of all. And S means sclerodactyly. Pulmonary features we can see in this X-ray: infiltration, clinical manifestation, dyspnea, dry cough, and maybe present alveolitis and even right heart failure because high blood pressure in lung artery in the after some years form. And also we have pictures of wrist may disappear, distal funks, maybe spontaneous necrosis in this disease. Okay. And different other features which are present in this slide also maybe T about telangiectasia. We can see skin changes, very specific. Also, we can see skin changes with atrophy, mouth aperture, and some absence of distal funks. And for treatment, we use specific depincelamine. It's specific chemotherapy for fibrosis. We also may use biological agents and other chemotherapy like methotrexate, azathioprine, cyclosporine, even cyclophosphamide, and also we use symptomatically treatment. We use specific protectors for vessels, and we use drugs which lead to elevate of circulation in the microvessels, and also we may prescribe non-steroid anti-inflammatory drugs in any cases, and but think about side effects of this drug. Minor form of systemic sclerosis, minor form of scleroderma present in this slide. And next disease polymyositis and dermatomyositis. Also very uncommon disease, very rare disease. Environment factors may be triggers after any drugs, after any infections, ultraviolet light, vitamin D deficiency discussed in pathogenesis, smoking. And genetic factors also, we review some type of HLA system which is responsible for this disease. Quantity of this disease is very, very rare. 5 cases per million per year. In average, female more than men, age 40-60 usually. And we have pathogenesis, which includes T and B cells and production of specific antibodies, activation of humoral mechanism of immunity. We can see pictures about it. Okay, and clinical manifestation. First of all, pathophysiology of this process. Microvascular includes involvement of microvascular chains includes increased thickening of endothelial cells, both of capillaries and venous, and we have myositis as a result, and systemic proximal muscle weakness is manifested as difficulty in getting up from sitting position, climbing stairs, lifting heavy objects, and overhead abduction of the arm. And skin rash also possible if present dermatomyositis, if also only myositis is impossible. Gutron papules, heliotropic rash, pathognomonical skin findings of dermatomyositis. We can see these pictures with heliotropic rash, with Gutron papules, usually in the fingers, metacarpophalangeal, proximal interphalangeal, and distant interphalangeal joints. Also Gutron signs. Okay, maybe erythematosus rash on the anterior chest and upper back. Maybe dilated capillary loops at the base of the fingernails, irregular and thickened cuticles, and cracked palmar fingertip. And poikiloderma may be present in the lateral part of thigh. For laboratory tests, we use creatine phosphokinase, myoglobin as a marker of necrosis of muscles, and also may increase LTSD, lactate dehydrogenase, aldolase, and the presence of specific autoantibodies present in more than 80% of patients. Myositis specific antibodies, myositis associated antibodies we can find. It's about this type of antibodies. And electromyography also reveals some changes: low amplitude, short duration, polyphasic potential, increased membrane irritability, spontaneous fibrillation may occur. Early, we can see pictures about it in the bottom. And muscle biopsy abnormalities with inflammation, mononuclear inflammatory cells infiltration, and atrophy of muscle fibers as a result may be present. It's histological picture. Okay. Chest X-ray should be review of infiltration changes, interstitial lung damage, and CT scan we also use. For treatment, prescribe corticosteroids, 1 or 2 milligram per kilogram per day, and sometimes we use as constant treatment. Sometimes we use big quantity for pulse therapy. Methotrexate and azathioprine also can be used. Cyclosporine or tacrolimus are effective in treating skin manifestation. Mofetil mycophenolate also may be used. And new drugs, biological agents, rituximab, anti-CD20 monoclonal antibodies is very effective. Okay, we have 3 diseases in one lecture. Of course, it's not full data, but we should learn more about this disease. And for today, it's enough. Thank you for your attention. Goodbye.